The 30th of October, and we're going to be looking at fluvoxamine, which is a common antidepressant, but it's been shown to have significant protective effects in preventing hospitalisations and deaths in people who've been diagnosed with COVID-19, quite significant. Now, the big thing about this is it costs about $4 a course. In fact, you could probably get it even less than that. Two capsules a day for 10 days, total cost for the whole 10 days, $4. And this means it could be really, really important in poorer countries where $4 is probably about the amount of money that some people can afford. Now, hospitalisations seem to be reduced by about 32%, and deaths seem to be reduced by about the same, coincidentally, of about 32%. That's from different figures and statistics. So if someone said to me, take this tablet for this capsule for 10 days, twice a day, and it'll reduce your chances of dying by 32%, I would bite their hand off, especially as it's a well-established, safe, or as safe as we can say the word safe. It's a very well-established drug. I mean, to be quite honest, I've taken a course of these type of drugs before, selective serotonin reuptake inhibitors, the common antidepressants, and I know a lot of you have as well. They are very well tolerated, very well-known group of drugs. So quite an exciting development, really. There's some reasons why it might not be implemented very widely. We'll look at that later. But that's what this video is about. So without further ado, let's go straight on to the detail now. Now, this is the paper here from the Lancet, published in Lancet Global Health. And the full paper is there. You can download a PDF. You can print it out. It's all available free and public domain. And it's a report, as you'll see from this, the Together trial. Now, this Together trial is a collaboration between scientists and doctors in academics, scientists between the United States, Canada and Brazil. So quite an international collaboration looking at repurposing drugs. If you want to know more about it, there's a video there. There's a full website on it there where, again, all looks pretty straightforward and pretty straightforward public domain stuff. And while we're looking at these pictures, I think I will just show you this one as well, just to show you that this is a very well established drug. So this is from the National Institute for Health and Care Excellence, from the British National Formulary. Fluvoxamine, well-known drug. It's called a selective serotonin reuptake inhibitor, which is the common group of antidepressant drugs, by far and away the most common antidepressant drugs prescribed, safe, not to be confused with benzodiazepines, which can be unsafe and habit forming, to put it mildly. Indications: depressive illness, and very often when it's accompanied with obsessive compulsive disorder. So we're in very much known territory here. So this is why this is so encouraging and readily available. Now, this is the paper here, the effect of early treatment. So the treatment in most people was in the first 3 or 4 days after they got symptoms. Some people it was up to 7 days after they got symptoms. So fairly early treatment with this medication. So as we've said, Lancet Global Health, all the references are there. Don't take my word for anything. Click on them. That's the COVID trial. Now, the background, potential therapeutic role for fluvoxamine has been noted. Does it work? This trial was there for that. Now, there was a small scale interventional trial before this which looked positive, and there was a fairly large scale observational study from France also looking positive. So this is the third positive study now, but this is now a proper trial. So part of the Together trial assess the efficacy of fluvoxamine versus placebo, as of course we would, exactly what we would want in an interventional clinical trial, and that's exactly what this trial does. In preventing hospitalisations and preventing, some people were already hospitalised, so it was preventing people being transferred to a further hospital and looking at the amount of people, the time people were in hospital, if they had to stay in hospital for more than 6 hours in an emergency department. So it was preventing both of those. And it did, as we said, with an efficacy of about 32%. So that's pretty That's pretty good, considering it's always a risk-benefit analysis, isn't it? What risk am I taking for what potential benefit? So this is absolutely minimal risk. If you think about it, this drug's been taken for 10 days. Typically, I've always advised that people take courses of selective serotonin reuptake inhibitors for a minimum of 6 months, and then wean themselves off over maybe 2-3 months after that. So this could well be a year's treatment typically, but here we're talking about 10 days. And in fact, there's evidence in depressive illness that if you just take SSRI, selective serotonin reuptake inhibitors, for just a month or two, can actually make you worse. So it needs to be a long course, but this is only 10 days for this indication. So placebo, some were given a placebo, and it was controlled with this placebo group. Randomised, in other words, entry into the experimental group to get the drug, or to get the placebo, was on random allocation, which of course it has to be. It was double blind, meaning the people giving out the medicines and the people receiving the medicines didn't know which it was. And it's what you call an adaptive platform trial. Now, this is kind of the new way to do clinical trials. It facilitates an analysis at key points. So there was analysis in this trial, I can't remember when it was, but it's something like 2, 4, 8, 14, up to 28 days. So they could modify things if they needed to without influencing the overall results. That's the clever part, to make sure it doesn't influence the overall results. So study design parameters like sample size, dosage, or patient selective can be adjusted accordingly. In other words, this can be not exactly fiddled with, but adjusted given ongoing feedback as the trial goes through, and the trial can be adapted accordingly. So that's useful, and it's a way a lot of clinical trials are done now. But quite complicated to make sure that you don't influence with the results. But this has been well peer-reviewed and statistically analysed, so I'm satisfied that it hasn't. Now, this was in high-risk symptomatic Brazilian adults. So the studies were also it was largely conducted from Canada on patients in Brazil, with American United States statistical analysis. So it's quite an international collaboration. Now, the risks: people had chronic cardiovascular disease, uncontrolled high blood pressure, chronic lung disease, asthma, chronic kidney disease, rheumatological disorder, chronic neurological disorder, diabetes, autoimmune disease, other risk factors or comorbidities. So the usual, they had one or more of these. So in other words, these were the people that were likely or more likely to go on to deteriorate, most commonly in the second week after they'd been diagnosed. So they're selecting these high-risk patients, all age ranges. I think it was from 18 to 102. Just over half were female, so good sex ratio, and there was a good combination of Brazilian-based ethnicities as well. So this is a pretty good representative sample of humanity, basically. Which is nice. There were confirmed diagnoses with PCR from within 7 days, but many were in the first 3 or 4 days after symptoms. 11 clinical sites in Brazil. So all good, proper research stuff. I mean, this really is the gold standard of interventional research. This is how it should be done. Now, patients were randomly allocated 1-to-1. So one in the experimental group to get the drug, one in the placebo group not to get the drug, comparing them 1-to-1. So the experimental group got fluvoxamine 100 milligrams twice a day for 10 days, and there were 741 people in that group. So this is the experimental group here that got the new treatment. This is the independent variable group, or the experimental group. Comparing that to the placebo group, where the number there was 756. So clearly we have two groups. Treatment in there was the same, treatment in there was the same, except they got the fluvoxamine and they got a placebo, but they didn't know which it was, and the people giving out the drug didn't know which one it was. This is a randomised double-blind controlled trial. This is good stuff. So all very good research technique. Now, primary outcome they looked at was hospitalisation, patients being admitted to hospital, people being retained in hospital, or transferred onto a tertiary treatment unit. So related to hospitalisation. And of course, obviously, that is related to severity of the patient's condition and deterioration of the patient's condition. Carried on for up to 28 days post-randomisation. I think the first assessment was at day 2, then at various times after randomisation, all the way up to 28 days follow-up. Findings were taken from January the 20th to August the 5th, so again a good time period. The proportion of patients observed in a COVID-19 emergency setting for more than 6 hours was one criteria. If they're kept for more than 6 hours, obviously they would be sicker, or transferred to a tertiary hospital due to COVID-19. Now, this hospitalisation criteria applied to 87% of the patients. Well, the transfer was 87% of the patients. The minority were only kept in hospital for the shorter period of time. So, but either way, it doesn't matter too much. This was the majority of the patients, so only 13% were observed in hospital for a period of time. But the point is, these patients were sick enough to be hospitalised. They had deteriorated or referred to specialist care. That's the point. This is a marker for their level of deterioration. So, transfers were lower in the fluvoxamine group compared to the placebo. The fluvoxamine group did significantly, and of course we're using that term precisely, statistically significantly better. Precisely. Fluvoxamine group, 79% of the 741 were retained in hospital or transferred. That was 11% of them. Placebo group, 119, that's 16% of them, of the 756 were transferred to, kept in hospital or transferred for further treatment. So we see that more in the placebo group were transferred for further hospital treatment. We see that less in the fluvoxamine group were transferred for further treatment or hospitalised. Now this gives us what you call a relative risk of 0.68, and that's always compared to 1, of course. And as we've said, that gives us a 32% reduction in hospitalisation. They're 95% sure that the actual figure is between 0.52 and 0.88, and the probability that they are correct, that the probability that the fluvoxamine is in fact superior after their statistical analysis, which now I don't always follow all the details of these statistical analyses. You have to be a statistician to follow it. They had a specialist group of statisticians doing this in the United States, so it was done very thoroughly. So I trust the outcome, and the outcome is peer reviewed. As much as I understood the statistics, it is accurate, but I don't pretend I understand them fully. But the probability that the fluvoxamine is superior to the placebo is an astounding 99.8% likelihood, which is impressive. Now, moving on to deaths, the fluvoxamine group, there were 17 deaths. The placebo group, there was 25. For statistical reasons, they calculated that as an odds ratio, but again, you can still see it's a 32% difference between the 17 deaths in the fluvoxamine group and the 25 deaths in the placebo group. And there were 95% sure it was between 0.36 and 1.27, so almost certainly around that mark. Again, the 32% protection. But the thing about this is for very low risk. Very low risk. I mean, if you get a 32% protection, but there's a 20% probability of a serious side effect, of course you wouldn't want it. But with this, it's a well-known, essentially safe medication. And I just refer you to this. Again, this drug's been used, I think it came out it was certainly in the 90s sometime, early 90s from what I remember. The important safety information is there about selective serotonin reuptake inhibitors, and all the information sorts there. Again, all completely available, all public domain, all just sitting there waiting for you or any clinician to peruse it. Now, just before we go on, we will mention that the FDA at the moment is saying there's not sufficient evidence for or against the use of fluvoxamine, and this has not got through to the National Institute for Health and Care Excellent guidelines in the United Kingdom. So this isn't being acted on, nor has the World Health Organization made any declaration on this yet. Now, I'm hoping that, well, let's say that some people have suggested that in the past these organising groups have been detracted from putting forward therapeutics because they thought it might detract from the vaccination programme. I really hope that's not the case, because this could massively help people in poorer countries. Direct quote from the paper: no significant difference in the number of treatment emergent adverse events among participants in the fluvoxamine and placebo group. So basically, severe side effects weren't any different. Now, in the fluvoxamine group, 84 stopped taking the drug, 64 stopped taking it in the placebo group, but the absolute number of serious adverse events associated with fluvoxamine was actually lower than in the placebo group. So a few more people stopped taking the actual drug than the placebo, but the overall number of adverse events was lower in the fluvoxamine group, probably due to the fact that this has an anti-inflammatory effect, and that was making patients feel better. As it says there, it's anti-inflammatory. Now, of course, how is this working is intriguing. Now, some people are suggesting a possible antiviral effect, but we're talking about this paper today, and this paper didn't show any difference in viral clearance at day 7, which is the key time, the first week for viral clearance. So this paper gives no evidence for an antiviral effect, even though others are discussing it. But this paper gives no evidence for an antiviral effect. Therefore, how is it working? Well, it's known to be anti-inflammatory. It works on inside part of the cells called the endoplasmic reticulum, where it reduces inflammatory triggers. So it is anti-inflammatory, that's known, and therefore it would help to prevent the cytokine storm, which can cause the severe adverse effects, such as the acute respiratory distress syndrome, where the alveoli fill up with fluid and the patient can die of respiratory failure. Also, there's some antiplatelet activity with the SSRIs. This is true for all SSRIs. There's some antiplatelet activity. So is it stopping microthrombus? Could be. That's a possibility. I think this is probably the big one here, with a bit of anti-inflammatory effect as well. And also, SSRIs can increase the plasma levels of melatonin. That's why often when people start on these, their sleep improves quite dramatically at a fairly early stage in taking the treatment. So it's now crucial to establish whether there's a class effect. In other words, is this true of all selective serotonin reuptake inhibitors? So the one you've probably heard of is Prozac, which is fluoxamine, which is a World Health Organization approved essential medicine. So is it the same if you take fluoxetine as if you take fluvoxamine? We don't know. That needs to be established, because Prozac, the fluoxetine, is probably more readily available. Or this can be made very readily available, as we've said, for $4 a course anyway, so shouldn't be too much of a problem. Now, most of the patients in this study in Brazil are actually not vaccinated. So what's the level of protection in patients that are vaccinated? Is it higher? Well, obviously you would expect it to be way higher, but we don't know the figures. And this is the standard nice thing that we've said, 50 to 100 milligrams daily. So it's higher than the normal dose, although this does say that you can build up to a higher dose. But of course, it's only for a 10-day period as opposed to months. Increased, if necessary, up to 300 milligrams daily. This says in the NICE guidelines for depression and obsessive compulsive disorder, whereas this study was using 200 milligrams. So there we go. Pretty interesting study, really. Now, for those of you that are interested, I'm just going to tell you a little bit about SSRIs now. So let's just have a quick think about that. Now, what we have, that would be a nerve fibre in the brain or central nervous system. And the end of the nerve fibre, this would be the end of an axon. So it branches out, it sort of bulbs out like this into what you call a synaptic end bulb, like that. So you get a wide bit of the neuron there. Then there's a membrane along the bottom there, and then that's it. So the nerve impulse would come down here in electrical form, and then it can't get. Well, once it gets to the end there, it can't jump across. Now there is another neuron here. So typically there'll be another neuron there, but there's a gap between the two. So there'll be another neuron there taking this fibre off to some other useful place, like that. Taking that off to somewhere, that's probably going to be a dendrite to another neuron. And that will carry on the electrical impulse if it can get there. But the electrical impulse can't get across this gap. That gap, of course, is called the synapse. The synaptic gap. So this is the presynaptic neuron here, before the synaptic gap, and this is the postsynaptic neuron here, after the synaptic gap. Now, what happens is in the presynaptic motor, in the motor end plate here, this wider part of the presynaptic neuron, there's some mitochondria here that provide lots of energy for this process. Then what we have here is vesicles of chemical transmitter fluid. So that's vesicles of chemical transmitter fluid there. Now, I'll draw those in red maybe. Now, well, when a nerve impulse arrives down here, that actually affects some of these vesicles. And some of these vesicles merge with this membrane here. And you can probably see it would make sense to call this membrane the presynaptic membrane. So that membrane there is the presynaptic membrane across the bottom there. So some of these vesicles merge with that, and that allows the chemical transmitter substance out into the synaptic gap, which is very microscopic. So within tiny fractions of a second, this chemical transmitter is able to diffuse across the synaptic gap. Now, when this chemical transmitter gets to this postsynaptic membrane here, that postsynaptic membrane, what it does is it depolarizes, it changes the polarity of that postsynaptic membrane, and that's what generates a new electrical nerve impulse. And that will carry on down this second neuron here. So what we have is electrical transmission here, chemical transmission across the synaptic gap there, and then ongoing electrical transmission there. So the idea initially was that in depression, you're getting impulses, nerve impulses here in parts of the brain, but you're not getting enough nerve impulses there because the nerve impulses aren't getting across the gap. And it's the lack of nerve impulses in this postsynaptic neuron that caused the depression. Now, of course, this has been modified since then, but this was the original idea. It was called serotonin deficiency depression. So serotonin is one of these chemical transmitters. So this would be serotonin here. That's serotonin there. Now, if serotonin is released from there and it depolarizes that postsynaptic membrane, you only want it to depolarize that postsynaptic membrane once. So if the serotonin was hanging around in the synaptic gap or the synaptic cleft, it would be causing continuous postsynaptic membrane depolarization, which of course you don't want. Otherwise, you'd end up with one nerve impulse here and 100 here. So you have to get rid of the serotonin from the synaptic gap after it's done its depolarization, caused its next electrical impulse to be propagated down the postsynaptic membrane, but doesn't keep stimulating this. So what happens is some of it is broken down. So there's enzymes in here that will break this down into inactive substances. So there's some enzymic breakdown. But that's not very efficient. So what happens a lot of the time is that the chemical transmitter simply goes from the gap and it's simply reabsorbed back into the presynaptic membrane so it can be used again. So it's released, depolarizes the postsynaptic membrane, then it's reabsorbed. It's reabsorbed back into the presynaptic neuron where it can be used again. Now, the idea in deficiency depression is you don't have enough serotonin. You don't have enough of this chemical transmitter depolarizing this postsynaptic membrane. So the idea is, how would you increase the depolarization of this depolarization of the postsynaptic membrane to make more electrical impulses here? Well, of course, to do that, you would need more serotonin to stimulate it more. So how do you get more serotonin? Well, some antidepressants will inhibit the effect of the enzymes, but they're a bit difficult to use. We don't really use those type much anymore. So what we do now is we have selective serotonin reuptake inhibitors. So this membrane here, the selective serotonin reuptake inhibitor, will make this membrane here more impermeable to the reuptake of serotonin. So we don't reuptake the serotonin. So if we're not reuptaking the serotonin, I think you can see that means the serotonin is retained in the synaptic gap and will cause more postsynaptic depolarization, therefore will stimulate that neuron more. So that's what selective SSRIs do. They're selective serotonin reuptake inhibitors. So other chemical transmitters are allowed to be reabsorbed for reuse because there's other chemical transmitters there. as well as serotonin. But these stop the reuptake of the serotonin. They're selective serotonin reuptake inhibitors. Therefore, more serotonin left in the synaptic gap. Therefore, there's more serotonin. Therefore, the deficiency depression is treated. We are no longer deficient in serotonin. Therefore, the electrical activity in the postsynaptic membrane is carrying on. Now, depression, of course, is nothing like as simple as that, and we could talk about this for months. There's a lot of other factors there, but that is the basic effect of what these selective serotonin reuptake inhibitors are doing. That's the way they work in. That's the way they're postulated initially, at least when they first came out. They were postulated to do that in depression, and they do work in depression. They work for me. They've worked in literally hundreds of other people that I've talked to, both professionally and non-professionally. That they are effective drugs, and most people can get off them fairly readily after, as we say, 6 or 7 months as well, with, for most people, a very minimal side effect profile. So that's the way they work in depression. But it now seems the selective serotonin reuptake inhibitors, as well as reducing the reuptake of serotonin from the presynaptic membrane, are also having this anti-inflammatory effect, preventing the cytokine storm, and also the antiplatelet effect. And the jury is still out as whether they have an antiviral effect. If they do, it's probably not a very big one, but that's the way. So it's been repurposed. So common drug, readily available, $4 a course. Other drugs which could be mentioned, such as what do you call it? Well, remdesivir is expensive. We know that, and the other one that's being applied for emergency use authorization now is the molnupiravir. The molnupiravir is about, I think I worked it out at $705 a course, so this one is a $701 a course cheaper. It has a known safety profile, which is good. Even if the efficacy is a bit less, it's going to be readily available in places where the monoclonal antibody therapy is not available, and could be a very, very effective home treatment. So as soon as someone's diagnosed in a high-risk category, they could be put on fluvoxamine, because it's readily available on every prescription computer screen and prescription pad, and it could be started with 32. And if the 32% reduction of hospitalisations and deaths is confirmed, I would be up for it. Big time, I'd be up for that. Yeah, brilliant. So there we go. That's all I know about that. So thank you for watching.